Dr. Raguraj Hegde.
Good morning. So I'll be presenting clinicopathological spectrum of IgG4 related orbital disease and management and outcomes. So the aim of study is to study the spectrum of the histopathological changes seen in IgG4 related disease and a summary of how it presents to us and imaging features, as well as to explore how early diagnosis helps in management. Management of principles and outcomes, and also IgG4 related disease is actually a systemic disease with localized presentations. It can be completely systemic, or it can be managed in a localized presentation, but it is always a systemic disease. So we have to treat it as a systemic disease, and the treatment also will reflect that. So this study was basically a multicentric study involving 4 tertiary hospitals in the same city, Bangalore, over 12 months. So we had 15 cases in the 12 months. The basis of diagnosis was on the criteria of the Gogo-H et al. In 2014. That's for the ophthalmic IgG4 related disease. And once diagnosis was made, correlation with demographics, site of involvement, laterality, and then of course we did a systemic workup with serum IgG4 related disease levels, and then after that the outcomes, the response to the steroids and the immunomodulators. So just to highlight a few atypical presentations, patient presented with bilateral recurrent bilateral proptosis involving resolving with oral steroids easily. He went on with multiple courses of steroids without anybody trying to attempt biopsy. So when they came to me, the patient presented like this. He had already a enucleation done, which the cause of which we didn't know what it was for. And then on MRI, we could see that there was a bilateral orbital involvement. All paranasal sinuses were involved with the lesion. And we went ahead with the exploratory orbitotomy with a multi-layered incision biopsy. So on histopathology, we could see that there was perivascular sclerosis was seen, and plasma cells were seen, but with sclerosed vessels. It could also be because of the steroids that were given earlier. The classical changes were not seen. And but when we did the immunohistochemistry and we saw that there was a transmural phlebitis and positive IgG4 positive plasma cells were there. So this satisfied the criteria for the pathological diagnosis of IgG4 related disease. So he started on rituximab therapy, and then he's on follow-up with mycophenolate mofetil for the long-term immunomodulation, and now he's in full remission. He's in plan for socket reconstruction for the left socket. Case 2, again, bilateral painful proptosis. So this is a fresh presentation. We were suspecting lymphoma, and because we thought it would become, it was probably a benign lymphocytic infiltration, so it could have progressed to lymphoma by the 5 years duration. And but his serum IgG4 levels were very high. And again, IgG4 is to IgG ratio is 40%, which again, but on histopathology though, there was no classical storiform fibrosis or obliterative fibrinosis. But on closer view, there was extensive lymphocytic infiltration into the, mild fibrosis was also seen, and also the plasma and lymphocytic infiltration into the tissue. Immunohistochemistry confirmed that there was IgG4 positive staining, and it was satisfying criteria. You just have to be 50 per high power feed, but here it was 200 on 400x. The results was basically 42 years, patient, mean age was 42 years. It's 13-year-old patient was the youngest patient, and lacrimal gland was the thing, and it had good response to immunomodulation, especially rituximab. In conclusion, orbital IgG4 related disease is frequently misdiagnosed because it's a very new entity. It is only, the criteria only came in 2014, and pseudotumor is actually a meaningless diagnosis in a pathology report. So we should encourage our pathologists to do more. And normally IgG4 related serum levels will not rule out IgG4 RD. So without a proper diagnosis, it's very challenging to treat these diseases because they are very recurrent, and they come back very frequently, and it's because it responds to steroids. There are multiple doses of steroids. So we have a case for early early induction of immunomodulation in these cases. So very deep understanding of this pathogenesis is important, and since it's a very new entity, our understanding of the disease also is progressing with it. Thank you.
Thank you, Dr. Raghu. I just have one question for you. In patients with idiopathic orbital inflammation, suppose you suspect idiopathic orbital inflammation, do you routinely give the samples for immunohistochemistry?
No, I let the pathologists take a call on this, but many of the general pathologists, they don't go ahead with immunohistochemistry. But we have a ophthalmic pathologist in Bangalore, so I go by what the pathologist says, and if they are suspecting, and because their clinical suspicion is very high, in many of these cases they didn't have a classical storiform fibrosis and those things, so a general pathologist would not send to IHC. But for her, she has seen that lymphocytic infiltration and gone ahead and ordered IHC staining, and she was right. So basically, it's experience of the pathologist also matters. So I go with what the pathologist says. So most of the diagnosis that we are making, and the more diagnosis of IgG4 they are making, is because pathologists are getting better and they are diagnosing this entity, and so we have to push our pathologists to do more and see more, and our clinical suspicion also has to be very high. So we have to rule out IgG4 related disease in many of these cases which were earlier labeled as pseudotumor.
Because usually what happens is when we send the samples, in a case with idiopathic orbital inflammation, the pathologist gives a report saying this is the standard report. No?
So in many of these cases, if I'm not sending it, if it's gone to a third person, so I get this blocks back and I send it to my pathologist to have a review, because diagnosis is very important. Only then we will be able to go forward with which immunomodulators will work. Because steroids is not the answer for the long-term therapy.
Because I can see without immunohistochemistry, it's very hard for you to make a diagnosis of IgG4 disease.
So all my cases, if they have done a biopsy elsewhere and they've done, I get the blocks myself and get it seen by my pathologist.
Thank you.
Thank you.